Welcome, everybody. My name is Muriel King, and I'm with the Wound Care Education Institute, powered by Relias, LLC. And I'd like to take a moment to welcome you all one more time to the webinar today titled Clinical and Lifestyle Concerns with an Ostomy. This webinar today was made possible by a grant from Shields Healthcare. And this particular event has been created to provide an opportunity for education related to clinical topics that affect the wound care market today. WCEI, as you may know, is now a part of the Relias family and continues to have one goal in mind: to improve the management of wounds and ostomy for patients across the nation. We currently support over 20,000 alumni through resources, webinars, seminars, conferences, as well as certification courses in wound care, diabetic wound care, ostomy, and nutrition wound care. In addition, WCEI hosts the annual Wild on Wounds National Conference held in Las Vegas. During the conference week in September, there's an opportunity for those who wish to become certified to attend a certification course and receive the WOW conference as a bonus. Details can be found at woundseminar.com. Registration is now open, so secure the early rate now. And before we jump into the webinar, I just want to run through a couple housekeeping items. For those of you that are interested in obtaining educational credit, you will receive an email from WCEI within 24 hours after this webinar, and it'll include the evaluation for this program. You must complete the evaluation in order to obtain your certificate. You will have 60 days from today to complete it. Double check your spam folder for those emails after 24 hours. The program today is being recorded, so you will be able to view and share with your colleagues within 7 business days. There is a handout that's available. If you haven't downloaded it yet from your email, you can click the attachment in the handout section to the left toolbar to download or print if needed. The actual CE presentation should last about 60 minutes. So if you have any questions for Joy, please feel free to submit them in the question box at any time during the webinar. And if time allows, we'll do a live Q&A and she'll respond to your questions at the end of the webinar. You must be logged into a computer, a tablet, or a mobile device and viewing the slides. No credit will be awarded for those who do audio only. So at this time, the accrediting body for the program is on the screen now. You can check www.wcei.net/CME to determine the approved CE provider based on your license type. The planners of this course have declared no relevant conflicts of interest that relate to this educational activity. Relias LLC guarantees this program is free from bias. And now I'd like to introduce today's speaker, Joy Hooper. As an RN with over 20 years of wound and ostomy care experience, Joy has practiced in a variety of hospital and home care settings. She is a successful nurse entrepreneur as owner of Medical Craft LLC and Aprons by Joy Anatomical Apron. She is board certified WOCN as a CWOCN and by NACO as a WCC and OMS. Her informal and down-to-earth teaching methods enable students to learn easily in a relaxed and enjoyable environment. Joy is our lead instructor for our ostomy courses and also serves on the advisory committee for Safe and Simple. Welcome, Joy. It's a pleasure to have you today.
Hi, thank you, Dee. It's a pleasure to be here. So let's begin with our clinical and lifestyle concerns for people that have ostomies. So what we're going to go over today we're going to look at some resources for you to be able to help take care of your patients better. One of the things that we're going to discuss is peristomal skin irritations and what we can do to relieve some of those peristomal skin irritations. And then we're going to look at some specialty products and what can people do if they want to go swimming, because summer's just around the corner, and by golly, we want anybody that wants to get into a pool to get into that pool. So let's begin with talking about the different terms when we're talking about an ostomy. You hear the term ostomy and stoma being used interchangeably. And actually, these are two different terms. When you're talking about the ostomy, that's the surgery, a colostomy, an ileostomy. Those are the types of surgery. Stoma is the actual little red piece on their abdomen that you're looking at. Now, to better help you understand this, you know, if you've heard my webinar before, I am all about explaining what an ostomy is. So if you can, make your little camera screen a little bit bigger, because I'm going to go over a colostomy and an ileostomy. And I hope that you're going to better understand these procedures as we move through this presentation. All right, now before I get into it, let's take a quick tour through the GI tract. You chew your food, it goes down your esophagus and into your stomach. From the stomach, it's slowly released into the small intestine. And as this food is traveling through the small intestine, it's being emulsified by the muscular action, and it's being melted down by those digestive enzymes. And that's so the walls of the small intestine can absorb the vitamins and nutrients and take them to use for fuel for your body. After that chewed up food has traveled through all the small intestine, it's going to enter into the large intestine. And just as the small intestine ate for you, the large intestine is going to drink for you. It's going to absorb the liquid from the liquids that you drink and the liquid content of the food that you've eaten. And it's going to take that and use it for the nourishment and the liquid of your body. And then that excess is going to exit out of your anus. Now, to quickly explain a colostomy, somewhere in the colon, the surgeon will separate the GI tract. I've separated it right here in the sigmoid area. Now, they can completely remove this section, or they can leave it intact and simply close it up. If it's left intact, this little stump will now be known as the Hartmann's pouch. So let's just close it up, leave it intact, but we're going to have to do something because we've got stool coming out right here of this open end. So the surgeon creates a stoma. They create a stoma by on the outside of the abdomen, creating an opening to the inside. Then they're going to pull this open piece of bowel through all the layers on the inside the body, all the way through to the outside of the body. I created an end stoma right there. That's a very common procedure that we see with colostomies. Now, this opening was very close to where my anal opening would be, and I would expect the stool coming out of this particular stoma right here to very much be like what would have come out of my anus, that formed more solid stool. Now, there are times when somebody may have to have their entire colon removed. If they had to have their colon removed, they would simply be left with their small intestine. They can make a stoma off of the small intestine. Since it's coming off the ileum section, it's going to be known as an ileostomy, and it's the same stoma procedure where that piece of intestine is brought out, folded over, sewn down, and now this will be where this person's stool is going to exit their body. But the stool coming out of an ileostomy is going to be much different than what came out of a colostomy. Think about those digestive enzymes that were at work right there in that small intestine, and now it's coming right out of the body. Think of how caustic that would be on the skin. So I'll get back to more anatomy in just a few minutes, but for now, let's just carry on. Talking about the ostomies. These are quite common here in the United States as well as other countries as well. Most of the ostomies that we see are going to be fecal ostomies as compared to urostomies. We see about 120,000 of these surgeries annually. And of these surgeries that happen, over half of the people that have an ostomy are going to end up with some type of peristomal skin irritation. And for the people that have the peristomal skin irritation, it takes 3 months or longer for these areas of irritation to heal. So we want to make sure that we're giving really good education on how to prevent peristomal skin irritation as well as how to take care of it. So today, let's look at the 10 most common complications and solutions to solve them. We're going to begin with peristomal skin irritations. Now, you remember the last stoma that I created was the ileostomy coming right off of the small intestine? Well, that's very pertinent right here because your causes of peristomal skin irritation, the main one is irritant contact dermatitis. And you can remember that really easily by thinking, okay, what I came in contact with was very irritating to my body. This can be a reaction to some type of soap or a solvent that they're using to clean around their stoma. It can be from the product, from the adhesive. But this contact irritant dermatitis can also be from the person's own output, sometimes called their effluent. The output coming out of their stoma can be so caustic, especially if it's an ileostomy, that it can just erode that skin right down. Other causes of peristomal skin irritation, of course, pressure on the skin, shearing, a product moving around, the appliance not fitting correctly. It can be from too much pressure using a convex appliance. Now, we like convex appliances, but you've got to make sure that this is the right patient for them. Another problem that we can see is problems from pressure because they've got the ostomy belt just cinched down too tight as well. So we don't want to see any of those happening. There can also be peristomal skin irritation from friction. Friction from scrubbing, many times scrubbing the paste or the old adhesive off the skin. That scrubbing and rubbing can cause friction injuries. It can be from improper removal of that appliance, the person that just grips it and rips it off of their skin, rather than using the low and slow method of keeping both hands low to the body and removing it very, very slowly. Or maybe this is the person that does frequent pouch changes because they can't stand to see that stool on the inside of their pouch. So what are we going to do for a solution? First off, let's check and see what the person is wearing. Let's check for leakage. And the best way that we can do that is if you notice the picture right there, they're pulling that skin barrier away from the person's body, but they've got it held right in front of the person so they can see the back side of this skin barrier. You want to pull it away from the person's skin so they can see the back side of the skin barrier. Because if you look in the picture, you can see that there was a puddle of stool underneath the back side of the skin barrier. That would probably correspond with a red area on the person's body. So you want to get the patient in the habit of looking at the back of that skin barrier. That's probably going to be embarrassing for the person at first, but just tell them, hey, this is something that you need to make sure that you see. As a clinician, you want to make sure you're looking at the back of the skin barrier for erosion, looking for wear patterns. Also, make sure that the opening is cut to the desired size. They can use these little measuring devices that they get in your cut to fit type products, and make sure that they're cutting it appropriately. And you want a little bit of space in between the skin barrier and the stoma. We used to say 1/8 of an inch, but many manufacturers are getting away from saying 1/8 of an inch, and they're just saying slightly away from the edge. But what I found is people are like, well, what do you mean a little bit away from the edge? Because your idea of a smidgen and my idea of a schmidgen are going to be two different things. So I still say about 1/8 of an inch space in between the skin barrier and the stoma. And revise the system as needed. If you're seeing a client and they love the system, but the system is just not working for them, they're continuing to have leaks, see if you can encourage them to a different system. We want whatever is best for them. We want that reliable, predictable wear time. Another thing they need to do is make sure that they're cleaning that skin really, really good in between their pouch changes, using something mild on the skin. You know, fragrances are one of the most irritating things to the skin. So if you're using a soap on your skin, make sure it's not one with a lot of fragrances that can be irritating. You might only want to use the soaps when the person is in the shower rather than if they're doing the change just in front of the sink. I recommend for somebody who's changing their wafer and they're not in the shower and they're just changing it from the sink, only clean around it with water. You don't want to leave any residue of any cleanser on the skin before you reapply that next system. And if you're having a problem getting the old residue off, think about using an adhesive remover. They make adhesive remover sprays and wipes, and there's several different types and different molecular makeups. The newer ones are made of silicone, the older ones have a solvent. So try the different adhesive removers if you need them and see what one works best for you. Now, also for peristomal skin irritation, there's something called the crusting procedure. When you've got somebody who's got really raw skin, and you're looking at some really raw skin right there in the picture, this could also be called denuded skin, another term for raw. Now, the term excoriated is more of a linear erosion. So think of excoriated when somebody has scratched their skin. So we're not going to call this damage excoriation. Instead, we'll call it denuded, eroded, raw. Everybody knows what raw means. Well, the crusting procedure would make a pseudo scab or an artificial scab over this raw area, and that's going to give the product something to stick to, because the backs of these skin barriers don't want to stick to raw skin. So to do the crusting procedure, I'll go through the steps in just a second, but the idea of it is it's protecting the skin from when we go to remove that appliance from it. It doesn't provide an overall protection. I don't want you to think the crusting procedure is to protect from peristomal skin irritation. It's actually something to help heal it, but you don't use it for a preventive type resource. It is going to help absorb moisture in the area. As I said, it's going to increase adhesion by giving your product something to stick to. Hopefully, you're going to just do fewer pouch changes. And as it says, less disruption to the irritated skin. That comes from when you remove your appliance, it's going to lift up that crust and not interfere with that new epithelializing skin that's trying to close over that area. So to do the crusting procedure, to make this artificial scab, what you're going to need is a bottle of skin barrier powder, your regular stoma powder, a polymer skin barrier, and I'm going to use a little barrier white, like this right here, and a 4x4 is handy, and that's just to brush off the excess with. What you're going to do is you're going to sprinkle the powder on the irritated skin, and I'm going to pretend that the back of my hand has irritated skin on it. So you put the powder on, move it around. Now, of course, you would be putting this on irritated skin. That would start absorbing some of this powder right here, but since my skin's not irritated, of course, nothing's going to be absorbed. So I'm just going to go ahead and start doing the next step. And that is taking your skin barrier and moistening that powder. And you're going to do this for building up a couple of layers. Now, I typically just build up 2 layers, but I have friends that build up 3 or 4 layers, and they have great results in doing so. I just tend to make a big mess with it, so I typically don't go over 2 layers. But you can see I have created some of that crust right there. And it feels crusty. It is not soft like the rest of my skin. This is more rough. It's very dry. And whatever product I want to stick to it should stick pretty doggone well. And the great thing about it is when I go to lift the product off of my skin, it's lifting away the crust and not interfering with my skin. So that is the crusting procedure. Here are the different steps. All right, number 2. What is our number 2 problem? A flat stoma. Do you see more flat stomas than you see, protruding stomas? I do. I really do. And I used to think what most people think, the doctors just like to make those flat stomas. Well, that's not actually accurate. Let me go back to the apron and help explain something. All right, a second ago, I showed you the colostomy where I separated the GI tract. I pulled the open piece of GI tract through, folded it over, and created the stoma. Now I can do that, and I can make this nice protruding stoma right here because I'm working with cotton and fleece. However, the surgeon is not working with cotton and fleece, and many times what the surgeon is having to go through is a lot of fatty tissue. So let me put some fat tissue, also called adipose tissue, on, and let's do the same procedure. Now, as I pull this piece of bowel through, I don't have as much to work with because I've got to come through this adipose tissue. You see, the GI tract, it's not like a water hose where the surgeon can just loosen up as much as they need to. They've got to keep it attached to the blood supply. So they've got to be very careful with how much they separate. Now, when I go to create my stoma, I'm not going to have as much GI tract to work with, so I'm not going to be able to form that nice budded stoma as I did before. This stoma is going to be flat. It's not going to protrude. It may be harder for me to manage since it does not protrude. It also has some little creases right there on the side. So again, just from this being a flat stoma, it can be harder to manage. A flat stoma can be level with the skin, or it can be retracted below the skin surface. Now the problem is with your flat stomas, the effluent, the output from the stoma likes to leak up underneath that skin barrier, and it does it persistently and really irritates the person's skin, as well as shortens the wear time of the pouching system. Other contributing factors: obesity, having more of that adipose tissue on your body, again, not allowing that surgeon to pull through as much as they would like to. Also, sometimes there's scar tissue on the body that the surgeon's having to work around. Or it's just a short stoma to start with. Some people never knew that they had short bowel until they went in for ostomy surgery. It could also be from early removal of the loop, if this is a loop type stoma. So what can we use for a solution for our flat stomas? In a word, convexity. Now here is a convex skin barrier. You see it's kind of bowl shape as opposed to a flat skin barrier. All right, you see how that's outwardly shaped like a bowl right there. And in the picture, you can see why. In the bottom picture on the left, you can see that the stool is coming out of the stoma and it's just starting to puddle there and then leak over to the skin. Where the picture on the right, they've placed this convex barrier down over the stoma that's pushed the skin down around the stoma and encourages the stoma to pooch up or protrude up through the opening. We want that so the stool or the urine would be able to just fall right down into the pouch. You would want to use convexity on those stomas that don't protrude, those that are flush or level with the skin, or even those that are retracted below the skin surface. You can use them on stomas that just don't protrude enough, or you can use them on stomas that are nicely protruding, but that peristomal skin has poor muscle tone. Maybe there's dips or there's divots right there in the skin. You want to be careful with convexity. We have soft convexity that's hit the market now, but even with soft convexity, use your best judgment. If this is a new stoma, less than 1 week post-op, remember, we've got to treat this as a wound. This is a new, fresh incision, and we don't want to put too much pressure on it. So be very careful, even with the newer technologies. You want to be very careful if the person has some type of ulcer in the area, or especially if they have PG in the area. If they have mucocutaneous separation, and that's what you're looking at in that picture right there, mucocutaneous separation from where the stoma has separated from the skin all the way around it. You've also got to be careful using convexity if you've got a large hernia or if you've got a prolapse. Now, convex products can leave impressions or imprints on the skin. They can leave red imprints on the skin. If they're left too long, causing too much pressure, they can actually break the skin down and render the tissue necrotic, like you're seeing right there in the picture. Here are some examples of some different convex products. So you're looking at some different convex skin barriers, as well as some different convex rings that can be used to put on the back of a flat or a convex skin barrier just to give it more depth. Here's another example of the convex barrier ring, and these are available in oval sizes as well. Other things that we can do for that flat stoma, think about a belt, just that little 1-inch manufacturer's belt like you see there in the picture. That can really help enhance that convexity. So can your barrier strips. And some people like to use paste in there as well. Now, you've got to be careful, though, with your convexity. As I said, don't have that belt on too tight. But this is an example of definitely a stoma that I would choose convexity with. Maybe go around the stoma with some paste. Apply one of the moldable type rings, like the ring I'm showing right here. There's one stuck in the top right picture. Then go ahead and seat the skin barrier and make sure that you lay your hands on it to increase the warmth in that area and help that appliance really adhere well to the skin. All right, our number 3 problem is with urostomies, and that's mucus accumulation in the pouch. Now, why is there mucus accumulation in the pouch? Well, let me take off my adipose pad and stand back up, and I will show you why. Okay, now I've been explaining the different fecal diversions. Let me explain what a urostomy is. Now, a urostomy also goes by the name ileal conduit. And to do that, I'm going to plop me a couple of kidneys on. Now, I know that the kidneys normally don't sit in front of the GI tract, but it's a whole lot easier for me to do this demonstration by just plopping those little kidneys on there. All right, we've got our kidneys, we've got our ureter, we've got our bladder, and our urethra. Okay, now if someone had, let's say, bladder cancer, and they had to have their bladder removed, one of the frequent surgeries that we see done is called an ileal conduit. With an ileal conduit, what they do is they go to the ileum, the small intestine, and they take a section of the ileum, they seal off one end of it, and then they implant the ureters right into that little segment of GI tract. Now, of course, they put the GI tract back together, so the GI tract doesn't even realize this has happened. But they're going to create a new opening. They're going to make a stoma out of that little piece of ileum. They're actually using the ileum as a conduit. That's where the name ileal conduit comes from. So now you can see the ureters are draining into this little piece of small intestine that has been created into a stoma. All right, that might help you understand where the mucus is coming from. All of the GI tract is secreting mucus to help protect it, especially the small intestine secreting that mucus to protect it against those caustic enzymes in there breaking the stool down. So this little piece of small intestine that has been moved from the GI tract now to the urinary tract, it doesn't know and doesn't care that it's not part of the GI tract anymore. It just keeps secreting that mucus. And that mucus ends up in the urostomy pouch. And it actually can cause problems right there with the spout, being able to drain that mucus out. There are some different disbursement drops that you can purchase and put in there that are going to help break that mucus down. But what you want the person to know with a urostomy, and what you want to know for that person that has a urostomy, that the mucus in the pouch is considered normal. It's just letting us know that that piece of GI tract in there is still secreting some mucus. As I said, you can put the disbursement drops in there to help break up that mucus. Other things that the person can do is drink more liquids, especially things like cranberry juice or orange juice as well. All right, so that's a solution for that mucus accumulation. Our number 4 problem is that ballooning pouch, the buildup of gas from flatulence that happens in that pouch. The average person passes gas about 13 to 21 times a day. I bet you were thinking, not me, not me. Well, actually, we do that. Usually when we've got to pass gas, our brain tells our butt, oh, go somewhere private, you've got something to do. But sometimes it's just such a small amount of gas, the brain doesn't tell the butt anything. The brain's just kind of like, let it go, let it go. Well, if we don't have an ostomy, that gas is passing from our body right out into the environment. So nobody's none the wiser as long as there's no odor. However, if all of our gas was being trapped inside of a plastic pouch, just like someone with an ostomy is, we would be very aware of how much gas we put out during the day. So the person that now has an ostomy may say, look, I was not a gassy person before. Actually, you might have been, but you just weren't containing that gas, so you didn't know it. What we want the person who feels like they just have too much gas, what we want them to do is to keep a diary. Keep a diary of how many times you're having to burp or empty the gas out of that pouch. Also in that diary, note the foods that you're eating, because many times the foods that you're eating are going to contribute to the amount of gas that you have. Now, many foods, we're aware that they cause gas, dried beans, vegetables, corn, but sometimes there's foods that you're not expecting that can cause gas as well. Don't forget things like beer, things like soda. Also, if the person smokes or uses a straw, well, they can take in more air as they're eating, and this actually turns into the gas. Now, years ago, we didn't have the filters on pouches that we have now. And so what we used to do was take a little pin, and I'm reaching down to pick up my pouch that fell on the floor, sorry. We'd take a little pin and we would stick little holes in the tops of the pouch. But now our pouches have good filters on them, so we don't do that anymore, because more than just gas is going to come out of those little holes. Stool or urine can come out as well too. So don't be poking any holes in the pouch. Instead, go for the pouches that have a filter. You can see the filter right here in the corner of this pouch. Here's a filter on this pouch as well. You're seeing the filters on the pouches on the screen. And also you see the vent. The vent is a product that you can purchase and put on the pouch after you bought it. And it just helps vent, gives you a place where you can vent the air out. Now know that when the filters that have charcoal in them get wet, they stop functioning. So this is an example of a filter. Here's the charcoal piece in the top. What the companies do is they send you these small little stickers, and you just put the sticker right over that filter before the person showers or before they bathe or before they go swimming, and this is going to prevent that filter from getting wet. So if you wondered what that little pack of stickers was, it's to go over that filter. Okay, our number 5 problem is getting that good seal. Getting that good seal. We want the person with an ostomy to have a reliable, predictable wear time, to have the confidence to get out and live their life. If they don't have a good seal, it's going to leak, it's going to emit odor. The leakage can lead to skin breakdown. It can be very embarrassing. It can be humiliating for the person and just lead them to want to live a life totally at home, to socially isolate themselves. So the best thing that you want to do to help get that good seal is make sure that peristomal skin is clean and dry. Get all the old adhesive off of it. If there's hair in the area, they need to shave that area. And when I say shave it, don't so much go with that straight edge razor. Go with a little trimmer, the little electric trimmers that you can get at the drugstore or the beauty supply stores. And make sure the peristomal skin is dried thoroughly as well. For the products that you're going to be applying to the skin, whether it's the skin barrier or one of the little rings, make sure that you've warmed them to body temperature. And one way to warm it is just place it between your hands like this. I know women that when they're going to use these, they'll tuck it in their bra to let that get to body temperature so they can just pull it out and apply it when it's ready. So whatever you're going to be applying to the skin, if it's got this kind of pectin backing on it, warm it to body temperature between your hands before it's applied. That can help you get a better seal. Another thing that a lot of people use is stoma paste. But you know your stoma paste is actually a caulk. Paste is not an adhesive product. All right, it's a semi-solid product that we want to use as a caulking material to fill in the little gaps and the little irregular areas, but it's not an adhesive product. It is a great caulking product, but it is not an adhesive product, so don't confuse the two. Many of the older types of paste have alcohol base to them, and that can really burn right around the stoma. So if you are using paste, make sure that it does not contain alcohol. Now you want the paste, if you're putting it on the skin barrier, just as you're seeing in that right-hand picture, put it right around the opening, right around just the opening of that skin barrier, because your goal is for it to end up like the bottom left picture. When you apply it, you want this paste to come out and go around and fill in right around that stoma. So as I look at this picture and I see how paste is right around that stoma, there's a couple little open areas that I would want to fill in as well. But that's the principle behind paste. As I said, it's not an adhesive product. You only want to use a small bead of it. I would use a smaller bead than the picture down below. Some people actually put it into a syringe. I like putting it into a syringe to get that small bead of it. Now, most of the time, if you put it on the skin barrier, or some people like to put it on their skin right up around the stoma, that's okay too. But when you go to move it around with your gloved finger, it starts to stick to your glove. So if you just moisten it by rubbing your finger on a damp cloth or sticking it in a little bit of water, that's going to help you be able to manipulate this paste without it sticking to your gloved finger. If you're trying to remove the paste from the skin, probably the easiest way to do it is allow it to dry first. If you allow it to dry, sometimes you can flick it off of the skin. If you're not able to flick it away, now be careful picking it away. I'm talking flicking it to loosen any of those particles. Something you could do is come back with an adhesive remover spray or an adhesive remover wipe to help get that residue off. And if that doesn't work, put a warm washcloth on there. Moisten it up. See if you can't roll some of it up. You don't want any of this old adhesive residue or old paste residue left on the skin. Now, as I was mentioning with the paste, it is not an adhesive. However, the little rings like this, they are an adhesive. So they can help you get that really good seal. When you work with these little rings right here, they become very, very flexible, especially after you've warmed them appropriately. And after you've worked with them, you'll feel that they're very, very tacky on your fingers. And that's because they do have adhesive technology made right into them. Right, here's some examples of some of the different paste or the different caulks that are out there. Here's the barrier ring that I was talking about. I got concerned. I knew the slide was coming, but I didn't remember where it was. The barrier ring, this is it right here. Now these can be stretched. They can be rolled, just like you're seeing down there in the picture, rolling it up just like this. Okay, because different people like to use them different ways. Some people like to stack them together. Now it's also available in strip paste form, so you can get it already like this. And again, you would want to warm this to body temperature, but this can be stretched, it can be molded, it can be flattened. It can be used as a putty, as a caulking to fill in whatever areas you need to fill in. Right? And then there's very much some sticky, tacky residue on my fingers right here. Now, as I said, these rings do have adhesive in them. They're soft, they're flexible. They're allowed to touch the stoma, just like you're seeing in the picture. That moldable barrier ring is right in contact with the stoma. That's just fine. These are designed to be able to sit up next to the stoma, and they're not going to interfere with the blood supply. So here's some different examples of different barrier rings, moldable barrier rings. And as I said a second ago, it's available in strip paste form as well. You can just break this into smaller pieces and use whatever size you need. Okay, moving on to number 6. Number 6 is pouching tips for the people that want to go swimming. Well, after surgery has healed, there's no reason why this person with an ostomy shouldn't be able to get into a pool. We do want to make sure that they know they should always wear their pouch while they're in the pool. Some tips before they get in the water: empty the pouch, maybe eat a light meal rather than a heavy meal. If you're just putting on a fresh pouch that day, wait a couple hours after you put the pouch on before getting in the water, and definitely make sure you carry a change of supplies with you. Now, another tip is to wear that closed-ended pouch. This is an example of a closed-ended pouch. You don't drain it, you don't empty it, you simply remove it and throw it away. Wear one of these under your bathing suit as opposed to a drainable, because a drainable is going to either have a clamp or this Velcro type closure, which adds bulk to the bottom of it. So here's the reason why that suggestion is very handy. Now, you want to have that good seal, but sometimes the edges of the skin barrier will absorb moisture. So the way that you're going to prevent that is prevent moisture from getting to the edge of these areas. You can use products like your hydrocolloid flange extenders and go around them and just encircle the product, and that's going to prevent the edges of it from getting wet. It also helps with better adhesion as well. There are other products as well. There are products, the top right side right there is a product that is a transparent barrier film that covers the outside of the skin barrier, preventing it from getting wet. And then you're looking at a belt type device that keeps the pouch dry as well. Now, along with these devices, there are companies that make apparel especially for swimming that have little pockets or places for the bathing suit to house the pouching system. So you can find those online. I believe there's information in your handout about them. All right, moving on to the next little tip. That's managing effluent during that appliance change. Now, this is going to be a real handy trick for somebody who's got a urostomy or that really high output ileostomy. And what you do is you use an index card to help hold the effluent back. Now, this trick was taught to me by a friend of mine from the UK named Margaret Heel. Margaret Heel has been a WC nurse for years, and she came up with this grand idea. And Margaret's instructions are, take the index card and somewhere along the top of it, fold it back several times and run your nail across it. Now, Margaret says this is a very important step for you to do because what you're going to do is tear right along this folded edge. And you're going to tear so you'll have that soft, frayed edge. Okay, I'm going to pull off some of these little icky spaces. All right, you can see that I've pulled that off. It's not quite regular, but probably if I wasn't doing this on a webinar where everybody would have seen me, it would have been perfect. But you see, I've got this frayed edge. As I said, Margaret said that that's important for a couple reasons. Number one, the frayed edge is less likely to cause a paper cut. And you're going to see we're going to have this right in contact with the skin. Another reason is the frayed edge is going to wick up moisture where this cut edge is not going to do that. All right, so I've torn the edge of it. Next thing that I'm going to do is I'm going to wrap it around the stoma. The way I usually do it is I wrap it around my finger first just to get the little index card to where it's going to curl. Okay. And then just as you see in that top picture, they've got it wrapped right around the stoma, and then they're sliding the skin barrier right over it. Now, it's important to note that the stool is not just going to go right into this little piece of cardboard. You can take toilet paper and put in there, or if it's a urostomy, I usually use cotton balls because they're good about absorbing that liquid. So this little index card is going to act as a chimney or a receptacle for that stoma output to empty into, and the toilet paper or the cotton ball will absorb that effluent out. All right? And as you're seeing in the bottom picture, they're actually seating that wafer right over it. You could even do this with a one-piece pouch and then just let the little cardboard roll fall right down into the pouch and pull it out from the bottom. So a great little trick. And you can look in the references section of your handout and find where this has actually been written up as an article. Great idea, great idea. I call it the healing technique after Margaret Heel. All right, number eight is playing contact sports. Now, hey, we want that person that has an ostomy to get out and live a full life. And if they want to participate in contact sports, be it wrestling, a roller derby, or karate or judo, any kind of contact sport, we want them to do that. But we also want to make sure that they protect their stoma as well. So you're seeing the picture of the girl that is in the roller derby, and she actually does this. She wears that type of guard to help protect her stoma. And that particular guard also protects part of her pouch as well. So here are some more pictures of some different guards as well. And I've got one of them right here in front of me. And this particular little guard, this is the one that's down on the bottom. It comes with a plastic guard and several pieces of this Velcro. And you simply wear the guard if you want to. If you don't know to wear the guard, you would take it off. Now, a guard like this would be handy for somebody who was trying to protect their stoma from the seat belt. Or maybe you have that little 2-year-old child that you're carrying around on your hip and their leg is just rubbing back and forth across the stoma. This guard is good about protecting the stoma, although it's not going to protect any of the output from the pouch. Well, they do make larger guards that protect the stoma as well as the pouch itself. So Google that. Google stoma guard or stoma, ostomy, ostomy pouch protector. Any of those terms right there will help you find these different stoma guards. All right, moving on to number 9. Number 9, what if I don't want to wear a pouch and I've got a colostomy? Do I have any options? Yes. For many people that have a colostomy, an option from wearing a pouch would be doing colostomy irrigation. Now, colostomy irrigation was very popular years ago, but over the years, it's just kind of declined here in the United States. And some people say that that's because of the pouches that we've got now. Now we've got these closed-ended one-piece pouches that can simply be removed and thrown away. That's one reason people aren't irrigating. That's true. But I think another reason that people don't do irrigation is they're not taught about irrigation. And so that's where you want to make sure that there's that trained clinician, that certified clinician that knows all about ostomy, that's going to be able to help teach this person this option. So let's take a look at colostomy irrigation. What you're doing is you're going to insert water into the stoma. And what that does is it washes out that distal segment. That installation of water encourages peristalsis to occur, emptying out that distal portion of the bowel. And the goal is for this person's stoma to only pass the stool when it's been filled with the water. What this is going to do is eliminate the need for the person to wear a traditional type pouching system. And instead, they can just wear a little stoma cap. Now, a stoma cap, you're looking at one right there on the screen. It's like a small little mini pouch. And since they wash their bowel out or they empty their bowel out with the irrigation, they shouldn't have any output. However, the person can still secrete mucus. So you want to be wearing something to catch that mucus. Irrigation works on the principle that once the section of the large intestine is cleaned out, it's going to take anywhere from 24 to 48 hours for stool to return to the stoma. But you know, everybody's metabolism is a little bit different, and it also depends on the foods that you're eating, is how fast that is going to pass through your body. Now, who is going to be a good candidate for colostomy irrigation? Well, the person that has that descending or sigmoid left side colostomy is typically somebody that's a good candidate. You want somebody that's going to be dedicated to doing this, because this is not a fast procedure you're going to get in the bathroom and do and run out. This procedure takes anywhere from 45 minutes to an hour. And for most people, it's closer to an hour to do. So you want somebody that can dedicate an hour a day or an hour every other day to doing this irrigation. But by committing themselves for that hour, they shouldn't have to deal with the output for the rest of the time. Now, who is colostomy irrigation not going to work for? It's not going to work for somebody that doesn't have solid stool. So somebody that has constant diarrhea with a colostomy, you're not going to be a good candidate for this. Of course, somebody with an ileostomy or a urostomy, they're not going to be a candidate for it either. Other things that can take you away from being that candidate is if you have stoma stenosis, if you have a stoma that has prolapsed, if you have a really retracted stoma, or if you have a severe hernia. All of those can be contraindications for doing colostomy irrigation. Now, there are some detailed instructions right there in your handout, and there's also a lot of really good videos that are available as well. Number 10, where can I find reputable resources for that ostomy patient? Well, there's lots of great ones online, such as Shield's website. Shield's got a really great website for managing ostomies with their section about Asking Laura. And she's kind of the company's liaison to help get questions answered. Another great resource is the United Ostomy Associations of America. The United Ostomy Associations of America, they're an easy way to remember to get to their website, ostomy.org is one way you can get there, also uoaa.org. But they're pretty much the backbone for our ostomy resources here in the United States. And we rely on the UOAA for different information, such as the new patient guide. This is something that I give to all my new ostomy patients. It's a guide that's going to help them have something to read, a good resource for them to read once they get home from the hospital, that they can reference as they need to. The UOAA has a lot of information about what the different procedures are, your colostomy, your ileostomy, and your urostomy. And if you like the demonstration that I did at the beginning with my apron, I've actually produced some videos and put them on the UOAA website, so you can go to their website and show the videos of how I just explained the different ostomy procedures. Another resource could be you. Have you ever thought of becoming ostomy certified? Well, here in the United States, we've got 2 routes for you to go through. Consider being that resource yourself. You'd be very handy for your clients. You'd be very handy for your facility too. So consider going on and furthering your education when it comes to ostomies as well. All right, for the references, I'm going to thumb through these, but these will be in your handout, so download that handout and print it out. Now, I hope you've got some questions out there for me. And I'm going to turn this back over to Dee for the questions. How about that, Dee?
Awesome. Thanks so much, Joy, for this valuable information on ostomies and ileostomies. And I hope you all gained some knowledge that you can share with your colleagues and improve patient outcomes in your facility. This concludes the CE portion of the webinar. But before we move into the Q&A portion, I wanted to take a poll. After taking this, sitting here during this webinar, do any of you guys think you'd be interested in learning more about, I don't know, ostomy, wound nutrition, wound care, diabetic wound care? If yes, please select yes or no. This actual webinar was an intermediate level. And during the week, you'll have a full week-long class, and at the end, you'll be able to take your test and become certified. If you're interested, go ahead and select yes or no. What we'll do is probably send you over some information regarding our different courses that we offer, and then we also have some really great deals going on. Again, we mentioned the WOW conference. If you sign up for the course, you get to go to WOW for free in Las Vegas. The registration is free. However, your company or you will have to pay for your travel and stay. So go ahead and just select yes or no, and then we'll move right into our Q&A. Perfect. I'll go ahead and close that poll. And so thanks so much for your responses. And hey, Joy, you ready to hear some of the questions that came up?
I'm ready. I haven't seen them, but you can just read them to me if you don't mind.
Sure thing. So one of the questions was, how common are urostomies?
I would say I see about a third, maybe a little less than that for urostomies. Most of the urostomies that I see are going to be the ileal conduit, the one that I showed you. But I only see a third or less of ostomies that are actually urostomies. They're not nearly as many as I do with the fecal. Now that would be different if I worked in a different area probably, but right here in my area, I don't see nearly as many urostomies. For the exact number, you could go to the UOAA and they could give you a better percentage if you're looking for a number percentage.
Gotcha. For like statistics, that's a really good resource. Okay, so on average, how often do you have to change convex pouches versus the flat pouches to prevent skin breakdown?
About the same amount of time. You know, just because it's a convex pouching system doesn't mean that you're necessarily going to get a longer wear time out of it. Everybody is different. The main thing you want is that reliable, predictable wear time. And that reliable, predictable wear time, we want it to be somewhere between 3 and 5 days for that person, whether it is a convex barrier or a flat barrier. Now, let's say that you were using a flat barrier and you constantly had leakage and you were having to change it 2 and 3 times a day. And now you're going to switch to a convex barrier. And since the convex barrier is going to cause that stoma to protrude up and the stool to fall down into the pouch, well, that should lessen the leakage. So in that case, hopefully you're only going to have to change that convex barrier, you know, 2-3 times a week, as opposed to the problem with the flat barrier causing leakage. I hope that made sense.
Yeah, it does. Thanks so much. All right, so the next question I see here is do you have any tips for a loop ileostomy and fitting a pouch over a bar?
A loop ileostomy. Let's talk about what that loop ileostomy is. When they say loop, they're talking about a stoma. With an end stoma, the kind I made with my apron, the surgeon's going to bring up a piece of the intestine over the skin level, cuff it, and suture it down to the skin. This is an end stoma. It only has one opening right there. All right, that's an end stoma. The Brooks stoma. It used to be the only one that we saw. And then they came out with a loop stoma. Let me show you a loop stoma. With a loop stoma, they're going to pull a loop of bowel up over out onto the abdominal wall. They're going to put some type of stabilization rod up underneath it. Now, to allow the stool to get out of this loop, they're going to make a split and they're going to fold the back of this over. Now, I'm going to take this rod out so I can show you this right here. Now, they folded it back. Now, do you notice that I've still got these 2 openings into my GI tract? So I'm going to have a proximal and a distal opening with my loop stoma, 2 openings. Loop stomas, they can look like this. They can be that hot mess of a stoma. Sometimes you can see one opening, and sometimes it's not the opening that's putting out the stool. That's going to be hidden away. But sometimes you can see both stomas, and sometimes the surgeons perfect it to where it looks like a little tube hanging outside the body. Sometimes they put the 2 openings together. Let me show you why they like to do a loop. To take the loop back down or to reconnect the person, it really is just putting this back together. Okay, so that's a lot easier on the person's body than having that end stoma undone, pulled away, and then reconnected. So that's what a loop stoma is that they're talking about. All right, the problem comes in with you've got this rod right here, and if you pouch on top of the rod, many times you're going to end up with deep pressure injuries, and sometimes these aren't recognized. And so what happens is 4 or 5 weeks down the road, sometimes you go to remove that skin barrier and oh my goodness, now you've got a wound with depth in there. And the rod had been removed weeks ago, so you're wondering what caused this. Well, it was the deep tissue injury from the pressure of this rod. The ideal thing to do is to pouch up underneath the rod, but my goodness, that's so much easier said than done. The way that you can do that is with your skin barrier, measure around the stoma with one of these. Go ahead and cut the opening that's appropriate in there. You can make a couple little extra radial slits, cuts going outward. And then try and slide the rod as far as you can one way. Hook the skin barrier on here, slide the rod the other way, hook the skin barrier on there, and then make sure the rod is centered back in the middle. Now that works as long as your surgeons don't suture the rod down. If they suture the rod down, you're going to have to pouch on top of it. I wish there was an easier answer for that one.
Oh, that one's great. Thanks for being so thorough.
It's a problem. It's a problem.
No, we love it. So here's another question that me personally, I think it's a really good one, and I'm sure it comes up a lot, and let us know what your thoughts or maybe some tips are on it. How do patients deal with the psychology of having an ostomy? Is there a certain amount of depression or feelings of complete dependence upon an ostomy and not being quote unquote normal?
Oh my, this is something that actually I don't see as much of this now. I think because of the Facebook groups, there's probably somewhere between 1,500 to 1,700 different Facebook groups that are out there now. And I'm in several of the different groups, and the new people coming in, they come in so many times with this depression and saying, I felt so alone. I'm so glad that I found this group and found other people that are dealing with the same thing as me. I don't know of anybody in my area with an ostomy. I feel so alone. You know, people go into this surgery and they never had any idea they were going to end up with an ostomy. And some people had no idea that this would have even been an option. You know, take people that aren't into health care. They didn't know that they could make these diversions for the urine and for the stool, so it can be very shocking. And since we don't talk about urine and stool, it tends to come with this stigma of shame as well. So thank goodness for ostomy support groups, for Facebook groups, for social network in a way that people can interact. Because I do see a lot of people, I won't say that the ostomy brings on a depression, but it can bring on an isolation that causes the person to just isolate themselves away from other people. Maybe they're afraid of the odor. Maybe they're afraid of leakage. Maybe they're afraid of leaving their home because they're afraid they're going to have a leak. I can see that social isolation making people tend to want to be more depressed. So what we want them to do is get out, enjoy life. If you have the person that seems depressed and you don't know how to reach them, have that person contact the UOAA, or you contact the UOAA for that person and see if they've got some resources that can help. Great thing about the UOAA, a person is usually going to be answering the phone for them. So think about resources like that. I hope that helped.
Great. Yeah, that's really great, Joy. I'm glad that we were able to share that resource there. Here's another question.
Dee, can I say something on that same note? You know,
yeah, absolutely.
That person who had Crohn's disease that was living their life in the bathroom, having 30 bowel movements a day, and now give them an ostomy, and now this person's able to get out and live life. And this probably was something that they were dreading and something that they really had to push back on. No, I don't want to end up with an ostomy. But then they're given this ileostomy and they find out, hey, I can go to Disney now. I can go to Walmart because I can stand in a line now. So for some people, they're expecting this to be the worst thing that happened to them, and it turned out to be the best thing in their life because it literally gives them their life back. Now all they've got to learn how to do is manage that stoma and manage that pouch.
In terms of managing, a lot, and I think this is maybe the second time I've seen this question in the question box. One of the tools that's used to control effluent, it says they've been taught to use a tampon. Do you see any hazards to the patient doing this, maybe at home or, you know, something really quick while they're on the go?
Ooh, it depends on what they're doing with that tampon. It really does. You know, if they are taking it, think about how a tampon is, when it comes into moisture, it's going to swell. Some of them swell and become a big rectangle. Some of them swell up like an umbrella. And you wouldn't want to insert that into the stoma and then cause that to stretch open. I wouldn't want to do that because I would think stretching that area could just increase the possibilities of things like hernias and prolapse. So for me, I'm not going to be sticking anything in the stoma. However, if they wanted to put it at the end of their stoma to wick moisture up, that could be an option. But don't stick it in there. Don't stick it in there.
Good to know. Good to know. All right, so what would be the best treatment for constipation? And are the symptoms the same for constipation?
So let's say the person has a colostomy. So their output is very similar to what they had prior to ostomy surgery. But now the output is really thick. It doesn't want to come out and get into the pouch. Once it gets into the pouch, they have to squish it out, and it can just be very traumatic for the person. So what we want them to do is try and loosen up that stool. Now, there are lots of different foods that can cause the stool to be more loose. Many different juices. Think about the foods that give you diarrhea. And everybody's different on these foods. You would want that person to eat more of these foods. So maybe that's going to be grape juice. Maybe it's going to be cabbage. You want them to eat those foods that are going to help loosen the stool, as well as increase their fluid intake, water, juice, tea, whatever their liquid of choice is within reason. And increase activity as well. Be very careful on something like a laxative. We don't promote laxative use for people that have had ostomy surgery, and that's because the effect can be magnified when they have this shorter section of GI tract. All right, is that good, Dee?
Yeah, I think so.
All right.
So we have a little bit more time. We'll go maybe a couple more minutes. But here's another question, and it's a little bit long, so bear with me. How to better manage patients with colostomy and ileostomy with a mid-abdomen at the same time? Both ostomies are on the same side, and a wound vac is attached in mid-abdomen. We're having a problem on leakage most of the time. We end up changing the whole thing from wound vac to ostomy bag. They're looking for maybe some recommendations for that.
Okay, so what they're saying is they've got two stomas that seem to be pretty close together, and then not far away from it, they've got a large incision that they're having to use negative pressure on. So some of your different skin barriers are smaller in size than other ones are. All right, do you see the difference in these two sizes? Do you see how this one is a small one compared to kind of this one? That's the first thing you want to look for. The products that you're using may be small in size. You want products that are going to be flexible as well. Now, I know that this seal is going to be interfering with your negative pressure. So to get a good seal with your negative pressure, think about using things like your moldable barrier rings. Some people like to use paste on it as well. I'm more for a moldable barrier ring. But that can help you get that good seal up underneath there. If you're having problems with leaks, many times if there's a crease in the skin, you'll have problems getting that good seal with that negative pressure drape. Put some of this on there, and maybe that's going to give the drape something better to stick to. Something that I encourage you to do is reach out to your different ostomy manufacturers, whatever company you contract with, Convex, Coloplast, Hollister, New Hope, Marlin, whichever company that is, reach out to them and say, I'm using negative pressure. I have got two stomas within a very close proximity. Which products do you recommend, and how do you recommend that I use them? So many times that rep from that company is really going to be able to help you with this, because they know about what products can be smaller. They know about other accessory products that they can offer you to get a better seal too. That is a big problem. Now, also with negative pressure, there's the isolator strip, there's the crown, there's the funnel. Those are used with the KCI brand of negative pressure, but those are all little tools that you can use with your negative pressure whenever you've got a stoma or another wound nearby. So think about looking up those isolator strip, crown, and funnel. Think of looking those up.
Thanks, Joy. I think we have time for maybe one more question before we exit out, and maybe it can be a real short one. And this is, I've seen it a couple times. So this is the question: how is ostomy care different for children versus adults?
You want the same pouching principles. You want that reliable, predictable wear time. You want something that's comfortable for them. You want something that's discreet for them. The difference is usually the product that we put on their skin as far as cleaning their skin. And if it's a 2-year-old or 5-year-old, not that much of a difference. But if this is a newborn baby, a preemie, we have to be careful with things like our powders and our paste. We don't typically use paste. Instead, we would use a moldable barrier ring or strip paste, which is much easier to get off the skin. We don't use a solvent on a neonate either because of absorption issues. But if it's a child or an adult, it's still the same pouching principles. I hope that helped. Ask me one more,
Yeah.
Dee.
Actually, that's all the time that we have right now, Joy. Thanks to everybody for attending. And again, thanks, Joy, for all the information. I'm sure we have all learned a lot from you today. If you guys have any more questions, you can still put them in the question box, and we will send it over to Joy to get those answered and share the question answers. And at this time, that's all we have. Thanks so much again. And within 24 hours, you should receive the evaluation. Have a great day.
Bye, everybody. Thank you.